Hello, my name is Jesse Perez, and I am a operating room nurse circulator at Las Vegas VA Medical Center. And I want to present this project, which is a pre-op hyperglycemia protocol for total joint arthroplasties and open colorectal surgeries. The purpose for this project is to reduce surgical site infections. In collaboration with Dr. Rao, this protocol was created by Dr. Akeley, an anesthesiologist who is no longer with us. Additionally, I have found various reliable and recent literature that supports this project to improve the quality of care for our veterans. However, there is an inconsistency in following this protocol, and the goal is to maintain its recommendations to provide better patient care. What is this protocol and when to use? The pre-op hyperglycemia protocol is a perioperative intervention to control glucose levels to a safe glucose range, which is a suggested level to prevent surgical site infections per literature. It consists of a 3 sliding scales, low, standard, and high. It is initiated at glucose levels of 151 milligrams per deciliter. And this takes place at the pre-op area for total joint arthroplasties and open colorectal surgeries for patients admitted to the hospital after surgery. However, the pre-op hyperglycemia control is recommended for all surgeries. When the protocol is initiated, the glucose will be rechecked every 2 hours or as requested by the anesthesiologist. And this can occur at any part of the perioperative area, pre-op or in PACU. Why to implement this protocol? The main goal of implementing this protocol is to reduce surgical site infections, which are the second most common healthcare associated infection. According to Walters Kluwer, the Center of Medicare and Medicaid Services does not reimburse this type of infections. Second, standardization enhances efficiency, improves outcomes, leads to more predictable, consistent patient experience, and reduces cost by establishing consistent evidence-based practices. Third, prosthetic joint infections lead to severe postoperative complications such as rehospitalization, revision surgeries, or need for additional procedures that may last months, and prolonged antibiotic treatment, which may interact with the patient's comorbidities. As in most cases, total joint arthroplasties are performed in elderly and prosthetic joint infection patients undergoing 2-stage revision, which is the golden standard for this type of infections, cost nearly 5 times as much as the primary total joint arthroplasty. And fourth, according to Karoff 2019, in a cohort study of Medicare beneficiaries, of 125,000 open colorectal surgeries, 34% developed surgical site infections. Here are 4 evidence-based practice points that I like to add for this protocol. Number 1, there is a relationship between perioperative hyperglycemia and adverse surgical outcomes, including increased risk of surgical site infections, prolonged hospital stays, and higher mortality rates, which is well established in both cardiac and non-cardiac surgeries. Perioperative hyperglycemia impairs the body's immune system response by affecting white blood cells to fight infection and heal surgical wounds. Second, the CDC surgical site infection prevention guideline was updated in 2017 for perioperative glycemic control. This update recommends to have glucose of less than 200 for total joint arthroplasties. And the next is from an article from Matsuda 2023 that she mentions that 8% of surgical site infections are from gastrointestinal colorectal surgeries. For this reason, open colorectal surgeries are also an essential target for pre-op hyperglycemia control for this project. And last, although the optimal glycemic target is in the perioperative patients is not definitely established, a reasonable goal is to maintain blood glucose levels between 140 and 180 milligrams per deciliter to prevent hypoglycemia and hyperglycemia that may lead to harmful postoperative outcomes. Preoperative hyperglycemia management for medical societies. Various medical societies have similar hyperglycemia preoperative management. According to Drogba, the Society of Ambulatory Anesthesia recommends maintaining intraoperative blood glucose levels less than 180 for patients undergoing ambulatory surgery. The American Diabetes Association recommends a target blood glucose range of 80 to 180 in the perioperative area as well. The Society of Critical Care Medicine recommends initiating insulin therapy for critical ill patients with glucose levels of above 150. The American College of Physicians advises against intensive insulin therapy and recommends blood glucose target of 140 to 200. The Society of Thoracic Surgeons advocates maintaining intraoperative blood glucose levels below 180. The Joint British Diabetes Society recommends blood glucose levels of 108 to 180 for most patients. And the National Health Service recommends maintaining blood glucose levels between 108 to 180 in the preoperative area. The pre-op hyperglycemia protocol is located under the PACU/pre-op insulin orders on CPRS. It has 3 insulin sliding scales, low, standard, and high, and the pre-op nurse will notify the anesthesiologist to order it. Alternatively, the anesthesiologist could already have this in place for the pre-op nurse to follow. Once the rapid-acting insulin is administered, a glucose check will be done 2 hours after the initial dose given or at the anesthesiologist's request. Protocol insulin sliding scales. On the left side, we have the low sensitive insulin sliding scale, which is recommended for patients older than 70 with a GFR of less than 45 and non-history of diabetes. In the middle, we have the standard insulin sliding scale, which is recommended for patients not meeting the low or high sliding scale criteria. And on the right, the high insulin sliding scale is recommended for patients with BMI higher than 35, an insulin total dose at home of 80 units or more, and when they have a dose of 20 milligrams of prednisone or more. Well, thank you everyone for listening, and I want to add a few thank yous. Number one, Stella Point for guiding me to get this idea and talking to the right people. Second, I want to thank to Donna Rao for providing her feedback and allowed me to work on this project along with her. I also want to thank Dr. Pauls because she has also been supporting this project and providing me great feedback. And lastly, I want to thank Javette Fisher, 5 East Manager, as she is my master's degree mentor. Have a good day.